morning, everyone, and welcome to Northern Institute's People Policy Place seminar for November. And today our seminar is in collaboration with the Menzies School of Health Research. My name is Katrina Britnell and I'm the Partnerships Coordinator with Northern Institute. Firstly, I'd like to acknowledge the traditional custodians of the land on which we meet on today. And for those of us on site in Darwin, Northern Territory, it is the Larrakia people. We pay our respects to Larrakia elders past, present and progressing, and further extend that respect to any Aboriginal and Torres Strait Islander peoples joining us today in the room or online. Today's topic is Australian chemical, biological, radiological and nuclear health systems preparedness and governance. And it's going to be presented by Erica Van Ash. Erica is a former clinical nurse specialist in trauma and intensive care and a PhD candidate at ANU, School of Medicine and Psychology. So I'd like to ask Erica to please come up and present for us. Hi, Erica.
Thank you. Hi. Good morning, everybody, and thank you very much for attending this seminar series today. I would like to also acknowledge and appreciate that there are probably quite a few of you online or watching this a little later because of the cyclone events over the weekend, and to thank you all for actually being out there and for your efforts in supporting the community. I think it really highlights the multitude of issues across emergency services in the healthcare system, and by no means is that not acknowledged or underestimated. A massive thanks for everything that you do for the community. This presentation is geared towards discussing the future of healthcare, emergency services and public health within Australia. It is not a discussion about what organisations are not doing. It's a discussion about what could be done to harden, strengthen and make the healthcare system more resilient, but by no means a dig at what's not being done, the lack of funding. Oh, I need to go back one. Oh, you can use the keyboard. I need to go back.
Use the keyboard.
There's one. Yeah. Okay. Okay, so CBRN stands for chemical, biological, radiological and nuclear. Traditionally, an E has been added onto the end of that. There are academic discussions about whether the E belongs. I specifically choose not to address the E because E stands for explosives, detonations. And to keep this nice and clean, I discuss CBRN without the E. E, as per detonation, also implies blast injury, trauma from detonation, and it sort of muddies the water a little bit when it comes to talking about health systems. Blast explosives is managed in a traditional ABC trauma algorithm. So to keep this nice and neat, and in a lot of my discussions, I will only discuss CBRN, but it's not to exclude the E. It should always be considered as a co-trauma on top of the invasive trauma of CBRN. So CBRN is not a new topic. It's been around since before the First World War. We're all aware of, mustards and all the pictures of soldiers that have walked through clouds of mustard gas. Biological and radiological injuries are not new. They're just not as discussed because they're just not as common as a lot of the, run-of-the-mill trauma that we see and that we've been used to in warfare and in conventional warfare. But we are moving into an era where non-conventional warfare is becoming discussed, it's becoming considered. Dictators seem to be a lot less reluctant to hold back from mentioning that it is an option for them. And whether that's just a threat or whether that is something they are seriously considering, the fact of the matter is the dialogue is now out there, and unconventional warfare is becoming more topical because, you know, it does induce that fear. And do we respond to that fear? Yeah, I guess we have no choice to consider these things. It's a national gap. It's something that we haven't previously had to consider, and now we do. But the thing is that in considering all of that, even though it's not a new topic, it does present new strategic, operational, clinical and logistic challenges because we've never really tackled this properly before. Previous attempts have been made to get it up and running and off the ground. It just hasn't gotten up. And I would say that's because there's so many other competing priorities that need to be funded, addressed, given attention. It's workforce, retention issues. This is not sexy, it's not cool, it's not fun, it's hot, it's hard, it's arduous. And it takes very, very, very strong leaders to be able to lead a nation through a remediation such as this, and such that a healthcare system would be able to withstand a CBRN event in its true form. So Australia has been formally very slow to acknowledge the need for CBRN preparedness. We do not have a national strategy. We have an emergency plan. A new one was released. The Australian Emergency Preparedness Plan was released last year. But there is no overarching national strategy for CBRN and the after effects of a CBRN event. For casualty management, public management, community management. It's all embedded within the emergency guidelines, and those are particularly unclear, and much like many other things in Australia, the responses to that are particularly siloed within government departments at a federal and state level. So no one really knows who is leading this, but the direction from the government in the emergency preparedness guidelines direct that states govern their own CBRN response. Just to clarify, I'm not talking about CBRN response writ large. I'm talking about CBRN health response, and that is the casualty management after the event has happened. So how do we manage people after this has happened? What does the healthcare system look like to be able to manage the overwhelming numbers of casualties that could occur after a CBRN event? Traditionally in Australia, we have not trained enough people to retain generational knowledge and to pass the training on. So there have been moments in time where there has been a surge in the energy for this. And in that surge, we have bought some equipment, trained up some people. There's been interest. I think the last big time was the Sydney Olympic Games. And those have generally also coincided with United Nations directives as well. But there's never been a truly sustained effort to get this up and running, to ensure that it's inculcated in the national dialogue. And I'll talk about that on the next slide. So what has happened is that we've trained people to deal with this at the front line. So we have firefighters and we have an army troop that responds to this on behalf of the nation. And you might know it as hazmat, but it's more than just hazmat. It really means that our frontline staff are trained, but nothing beyond them have the ability or the knowledge, and then anything further reaching back than that, that goes on to operational procedural guidelines, national strategy, national policies to support this, governmental support for this, funding that supports this, capability chain management, stockpiling management, support to the national stockpile for the specific medications that are needed, hubs, academic reach out to support the big activities that need to get this up on a national scale have not been supported. And so people in the front line with the generational knowledge never really go up through their organisation and are then encouraged to manage the strategy reaching down. So the people with all the knowledge are at the front, and the people with all the power who hold the purse strings sit at the top. And generally, those are the people who do not understand the struggles of the people on the ground. And so the funding never comes down because the knowledge never gets up. And it's managed in the middle, but taken by people who are not specialists, twisted, diluted, and by the time it gets to the top, the information is somewhat minimised, irrelevant, and if it's not met with a national threat or intelligence picture that is scary enough, then there are just blocks in the middle. So you have a knowledge to power gap in this country. Everyone with the knowledge is at the bottom, screaming for attention, and everyone with the power doesn't ever meet those people. And that's a real problem in this country. Internal constraints dictate other priorities. We all know that we have an overwhelmed healthcare system. We have healthcare as a public good in this country, and that is an excellent thing. But how do you talk about remediating a healthcare system that needs great cultural overhaul to be able to manage this when you're struggling with overloaded emergency departments, burnt out nursing staff, emergency services, responding to crime and priorities that crime needs to be given the most and highest attention, or allocations of funding is given to things such as managing vulnerable populations. It doesn't leave a lot of room for remediation or manoeuvring or capability and asset management in a new field that is emerging. And so something literally has to be on our doorstep for it to become a priority. But even then, where do you find the staff? And it constantly brings me back to that saying, the best time to plant a tree was 10 years ago and the next best time is now. And we've been saying that for 20 years and we still haven't done it. So there's also the discussion about likelihood versus lethality. And it's a big discussion that they have, like in the Defence Force, sort of like how likely is this going to happen versus how lethal will this be? Well, problem with CBRN is it is a low likelihood. Intelligence pictures will feed that. It's ever present, potentially more domestically than it is internationally, but that threat is growing and we feel that at the moment, but lethally, a radioactive source at a port could clear a whole city, and a radioactive dispersal device going off in a city could wipe out thousands of people immediately, or have, a whole city's worth incapacitated with the long-term effects of cancer, thyroid disease, and things that you see in countries like Japan, Ukraine with Chernobyl, Bhopal in India. And so the likelihood's increasing. We know the lethality is high with CBRN, potentially higher than a lot of other traumas, but we just don't see it that often. And so I always think of a blackjack table, and I always think that organisational managers and organisational strategists play a little bit of blackjack with CBRN. Do we want more tanks, or, this is visible? Do we continue with ground warfare? Do we continue with submarines, or can we just hold off allocating that money on the off chance that that's really not going to happen? Like, Putin's making threats, but is he really going to do it? And you're sort of playing blackjack with this all the time. But those decisions have been made over a very long period of time to not prioritise this remediation. And so efforts that are being made on the ground by frontline staff aren't marrying up with any degree of concern, or they're being married up with a degree of opportunity cost. So what it's really going to take are some strong leaders to get together with people who do have the knowledge and generational experience to discuss what is possible, and we'll go on to that a little bit more. But in order to tackle this, we need some really, really strong national leaders to take this on and go, we're going to get to a point where we don't have a choice, but are we at the point already where it's a little too late for Australia? We've probably missed the mark. We're probably only going to get to a 50-60% solution before something happens. This is not a remediation that's going to happen over a matter of months or years. It's decades long, and we still have not started. We do have an opportunity, and one of the opportunities that comes with being the last country globally to really address this issue is that you're able to see what other countries have not done well and what they have done well. So we do have an opportunity to build a world-class CBRN system. So it's not all bad. It just means that we are in a position to do some real good. But we're in that position because we are one of the last countries in the world to acknowledge the problem and remediate. I'll just list off some global exemplars, and the reason I like to do this is so that you can see that things are happening around the world. This is some of the more notorious ones. You watch the news and you'll see that there are things and indications that things are happening all the time around the world. We're all familiar with the COVID-19 pandemic and how much that disrupted our lives, and it disrupted the healthcare system. But there are some you might not be aware of. So I'll just quickly go over these. And if you're interested, feel free to email me. I'm happy to send you journal articles or information on any one of these events. There are two that I'm particularly interested in, and they're probably not two that you would pick me for. So World War I and World War II, notorious use of chemical weapons. Mustard gases, people suffering with the effects of that immediately, skin burns, chemical burns that then turned into, varying degrees of leukemia, lymphoma, multi-organ failure. World War II, again, we saw the gassing of Jews in chambers from Cyclone B, and a range of other chemicals that were used, such as mustards, sarin nerve agents, and some of the radiological devices. Moving on, we saw the Chernobyl blast and the long-term devastating effects over decades that occurred in the Ukraine, and how that completely obliterated absolute regions. And the effects are still ongoing this day for the health and the welfare of the generations of children that were born to people that were affected by Chernobyl. And still to this day, the environmental impacts are well documented, and the United Nations runs a program in public health for that region, specifically tracking the effects of Chernobyl in the Ukraine. Bhopal, India was one of the largest, was the largest industrial accident that has been reported to date. 36,000 people affected, regions absolutely dislocated. It was an explosion in an industrial complex or industrial, power plant for fertilizer, and systematic issues with the management of the pipes, the heating, and failures in risk and safety management, training. It's incredibly interesting to look at the chain of events that occurred before there was an explosion. unfortunately, that explosion was the most devastating the world has seen, and not many people know about it. I won't labour into all of them, but if you see something you're interested in, please let me know. I will just quickly discuss Ebola in Africa, and I will bring this up in a later slide. But Ebola really brought to the fore how ungoverned many countries are at a national and strategic level, and how unaware governments are of the true state of their healthcare system when it comes to managing public health, community, and the internal machinations of their healthcare system in preparedness for non-conventional threats. I will leave that there. I will post-note it and we will discuss it a little later. I also want to discuss Guyana. So Guyana in Brazil was a dispersal of radioactive materials. I'm not sure if any of you are aware of it, but I found this fascinating. The reason I highlight Guyana is because, in my assessment, it's actually the CBRN event that probably most reflects something that could occur within the NT. Same temperature, same environment, same heat, same humidity, same sort of equatorial, band, same vulnerabilities, same sorts of population. In Guyana, a gentleman found a disposed X-ray machine at a dump and took it back to his mechanics workshop and pulled it apart. And he pulled it apart as such to the point that he found a capsule that contained a beautiful bright blue substance. And some children from the village were running through and playing in their father's mechanics workshop and found this blue substance and put it on themselves and then handed it around because they thought that it was magical and fantastical. And so people were taking this and rubbing it on themselves because it glowed. And the spread of this was absolutely huge. And people started getting sick. And it wasn't picked up. The machine was then on-sold. And so the radiation disease started spreading throughout the community, and obviously everyone who had come in contact with children that had touched this, and the adults, and the magical, dust, or the magical, blue stuff that glowed, became quite a severe radiation event. And it was only picked up by a journalist who realised what was going on, at which point quite a number of people were incredibly sick with radiation illness. Now, you're welcome to look that up. I can send you a number of articles about it, but what it really highlights is just how important it is that there is community awareness about the danger that just lies around us every day, and how susceptible vulnerable populations are to something even as simple in a dump to radioactive material. I think also because of the living conditions there and the sort of temperature, the humidity, as we know, chemicals and radiation love a bit of heat and humidity. It's a force multiplier for them. And this, for me, is probably the exemplar that in my PhD I would like to look at in a lot more detail, and to see how it correlates to conditions here in the NT, and how the NT would manage an event such as that. And as an exemplar for us, and looking into the NT, it is my belief that if the NT can actually get their CBRN health system sorted, it will set a fine example for the rest of Australia, simply because we are prepped and primed as the state to have the conditions that are best if you're a CBRN, terrorist, or worse if you're on the receiving end of, and that is simply because of our geographic nature, our vulnerable populations, our heat, our humidity, our meteorology, our wind gusts, our sand flow, and we have a lot of other conditions that are ripe for biological and bacterial breeding up here. So Guyana is a very fascinating historical exemplar for me, and it's certainly one I'm keeping my eye on for the Northern Territory. And just quickly, the Tokyo subway siren attacks, which you might all be familiar with, really is the exemplar that I like to take a look at when discussing logistic and capability management challenges, and what that looks like for infrastructure and the importance of good infrastructure within a city, that the healthcare system is not just reliant upon, you know, the hospitals, the staff, the management, the funding, the emergency services. It's very reliant on infrastructure being imaginative, accessible, flexible, you know, taking a look at what's possible and making sure that we are constantly imagining creative solutions. And so when you take a look at the subway siren attacks, you know, there were quite a few issues with public messaging. One of the big things was that their road system closed down because people panicked, and in an attempt to get to the hospitals, shut down the transport system. So those that got to the hospitals were all on foot, absolutely flooded the hospitals. But their whole logistics system failed, and that was a really huge global exemplar when you're talking about CBRN and when you're talking about a panicked population. That particular exemplar is used repeatedly because it really highlights the importance of government departments working together to solutionise healthcare solutions for casualty access and egress. The rest are no-brainers, and I'm going to have to leave them in the interest of making time. But if you have any others that you would like to discuss with me, feel free to send Jayan your question. I'm not very good with turning these slides. All right, so the current situation is that, you know, lots of other countries have done this. They acknowledged this was a problem and they got about it. And I think they, you know, they knew that these things do happen, and it's not just panic merchanting or hitting the red button. It's maybe it does happen, maybe it doesn't, but we don't want to be the ones to find out too late. Do we have an island mentality in Australia? I think we do. I think we're quite protected by our borders. We're protected by, you know, only having internal borders. But that is becoming far less of a situation as the globe changes and culture changes with that, and threats change with that too. But, you know, you take a look at the UK, who is incredibly well prepared for this, and the UK is prepared because it has, you know, generations of people that have grown up seeing photos of their grandparents in gas masks, with horses with gas masks on. They've walked around knowing this is a threat. They've walked around knowing that their borders are co-located with other countries that could be an enemy one day. They have populations of people that have never forgotten what happened in World War I or II. They all have uncles that had mustard burns. They've heard the stories. And more recently, you know, you see countries where people are buying gas masks off Temu, and that's not an unrealistic situation. You see the footage of Israel or Palestine and gas masks sitting out the front door so that people are ready to grab them. It's in their dialogue. It's in their survivability. We just don't have that dialogue here in Australia. We're not prepared, and we don't apply the personal safeguards that other countries don't have the liberty of ignoring. So I guess part of my PhD literature review is discussing, you know, is there an established link between governmental acknowledgement And by acknowledgement, I also mean funding, because people will always pay attention to something that's been given money. Is there a link to governments taking something seriously and stopping flipping the coin on an opportunity cost decision and academic research being endorsed? Is there a link between academics being supported to publish work and government endorsement of an issue? If a government doesn't endorse that there's an issue, are academics still able to publish, or are they coercively not encouraged to publish, in part because that's not where the money's going, but in part also because they don't feel supported, or they feel a little bit silly, or they feel a bit, you know, it's not an issue, you're being a panic merchant, the threat analysis is this and the government says it's not an issue. And so I went about sussing this out in my literature review. And I'll just go down, I'll flip a few slides and I'll go back up. And I've done a literature review for my PhD, and I took a look at whether Australia was on the national platform in academic literature for peer-reviewed articles. And do we have a platform? Are we present on the academic stage for academic literature? Are we showing up to global networking events? Is Australia a country that's taken seriously in this field of work? And as you can see, I've drilled down through my competence, and my search criteria is at the top. And it's quite broad and it's quite thorough. So it was CBRN, chemical, biological, radiological, nuclear, NBC, all hazards, health systems, emergency services, casualty, strategic, policy, national, preparedness, government, and framework. That was my Boolean language for my literature review search. And as you can see, I came up with, 2,378 articles to screen, and I went through a process of drilling down to see which articles met that criteria, looking for the most articles globally that hit this target and discuss CBRN strategic level discussions about their country or responses, and which countries are enabled in having a voice for or against their government's responses to remediating a CBRN healthcare system or in response to an event. And to see where there was national dialogue and national interest at an academic level in support or not in support of their government. And of those 273 articles, one is Australian, and that was written in 1998 by the AFP, endorsing that they are opening a CBRN intelligence cell, and I'm sure that still exists, but it's proof that all CBRN activity within Australia is internal to government and not necessarily supported external to government by academia, or that academics who do work in this area support governmental decision making and provide reference as specialists, but are not necessarily encouraged as authors to write about it or network at a very high level stage on behalf of Australia. Now, that's either attended by politicians, which I would argue are not the specialists and academics in this, or there's just not a dialogue, we don't buy in, we're not a part of the academic platform. And there are lots of other countries that really, really are, but we are not one of them. So one article in 60 years that meets this Boolean criteria that discusses the upper echelons of our strategic governance framework as it reports to the United Nations and the World Health Organization. I'm jumping all over the place here, but I just had to make that point. So just skipping back, the UN health regulations, the United Nations International Health Regulations really drive our global health security platform globally. And that is a part of the global health security agenda. It was spurred on by the failure to contain SARS back in 2004-05. And it really, in a nutshell, was the United Nations saying, we need a better reporting system. We can't keep having things spread and going from airport to airport, port to port, without other countries being aware that their screening needs to be amped up. I think I'm speaking to a lot of academics in the room, and so I'm not going to go on about and labour the international health regulations. But it's important because it leads me to my next point about the joint external evaluation. And this is where Ebola really comes to play for me. So the monitoring and evaluation framework of the Global Health Security Agenda is through the Joint External Evaluation of 2016, unless you're American, because the CDC uses a different tool to evaluate. And some countries do prefer that tool, and it's valid and it's relevant. We just use the Joint External Evaluation tool. But again, the Joint External Evaluation tool, as I understand it, and having spoken to a lot of other academics within Australia, is run internal to government. It's not necessarily something that is broadly shared amongst academia, and if so, it circulates back into the government. So Australia's true CBRN response capability sits in the Australian Army. I can't go on too much about that. It's a troop that I worked for a number of years and led. And the Army's response is something that I was very invested in for my time in the military. And I dedicated a number, 9-10 years to that particular cause as a specialist within the Army. So I did know that capability incredibly intensely. But the problem with having that particular capability and then nothing external to the Army means that you never truly remediate, and other organisations think, oh yeah, that's great, the Army's got that. But there's never an acknowledgement that the Army does have that. But if something happens, the Army is going to be offshore. That doesn't leave you with an Australian capability, because the Army's job is to support the soldiers that are supporting you. And so there's been this onus on the Defence Force to say we'll lead the way, but the Defence Force can't lead the way. It needs to be done by other organisations. And the emergency response plan circulates all of the organisations pointing to the other until you end up in a cul-de-sac that points back out to the other. And there's no real definition of what the CBRN response plan is or who is in charge for what. And so the joint external evaluation is conducted internal to government departments, but while it's run transparently, there's concern that it's not a true reflection of what is not available. And so it reports that there's capability, but that capability is not specifically CBRN dedicated. And so it potentially over-reports the ability of Australia to respond. And it's also, from my understanding, not wholly inclusive of Australia's academics that are not related to intergovernment departments. So it is not a true reflection necessarily of what we have. It's more a reflection of what they think we have. It's a paper review. No one's getting out there on the ground and looking. no one's asking the actual specialists or the frontline people who are doing the job, crying out, remember the knowledge to power gap thing I discussed? Well, no one, that's still not been bridged for these joint external evaluations. And so funding is not flowing from these, but as a multi-sectoral assessment, it's not as broadly available across academia as you would like to think. And I bring that back to Ebola because it is widely documented that this is the trap that Africa fell into with Ebola. The government had a false sense of security that they were prepared and ready. They had overestimated their health assets. They had overestimated their ability to respond. They had overestimated the public's ability to withstand, their, flexibility, adaptability, their capability, their capacity, their supply chain, their stockpile management. All of it was reported on and inflated, not deliberately. The process did not lead them to have a true governmental picture at a strategic level of what was required to remediate. So when Ebola hit, the whole thing just fell over because the government's picture of what was truly available really let the nation down and crunk their whole healthcare system in a matter of days. So, I use that as an example because it is widely documented that the joint external evaluation process, by its setup and by not reaching down to the people actually on the ground, failed the country, and as a result, the healthcare system was not remediated. The Australian National Action Plan for Health Security was developed, and it's quite a good action plan. It says all the right things, it does all the right things, but after that I just don't know that it has been as rehearsed or as broadly lent into as people would like to think, and COVID was a very good example of that. And we seem to have forgotten very quickly how much COVID affected everybody, and the impost upon the healthcare sector and the impost upon the public health management sector, and all of the echelons that COVID actually affected external to health within Australia, and the psychological and economic impacts upon family and how that relates to healthcare on a whole of healthcare continuum. So, we don't want to forget COVID, but it seems it's gone away. And unfortunately, we don't want another massive pandemic or a nuclear detonation or something to occur for us to be reminded. All right, this is just quickly, this is just a list of the American CDC and the technical areas that they divided the CDC into. You can go back and read this slide later. I've just put it up because it is a really nice example of how you could structure a Centre for Disease Control and cover all the echelons required to address a healthcare system and a society as a whole. America does do it really, really nicely. I found it really hard to watch Fauci during COVID up against a government that did not support him. The CDC in America is a fantastic organisation. Their model and their setup is an exemplar, and it's certainly one that I really hope Australia looks into when it's setting up its own structure and system, because these are 19 echelons or 19 departments that work interoperably, really, really seem to cover all facets of the multi-hazard spectrum with a view to health and public health from birth to death. We've covered that slide, I won't go on to it. So the Australian Centre for Disease Control is opening up in January 2026. I understand that a director has been appointed. I'm not sure who that person is. Congratulations. There are no clear outputs or definition of structure, but my understanding from speaking to a lot of other academics is that there's quite a heavy focus on biological and that there's no clear definitions for chemical and nuclear. Now, that will come in time, but you know, to set up a CDC, they need to go back in years and collect historical data to see what it is they're doing moving forward. And so that in itself is a huge impost in getting a CDC up and running. You know, we have some great exemplars around the world. The UK does this well. EU systems are fantastic. I love the American model. The Indo-Pacific really needs to find something that suits itself. We're not the US. You can't just like this, do that, and supplant the American model into Australia or supplant the UK model in. We have a separate government, we have a separate structure, we have Commonwealth versus state legislation and ways that we do things. I think that in looking at it, the outcomes need to be solely based on what is best for Australia and what is going to suit the Australian people with our vast populations and needs. That's probably a point that I really would like to labour, is that it's great to look overseas for solutions. It's great to go and find specialists from overseas. But if they don't have the governmental context, it may not be the right solution for Australia. And that's where it's so important that we do have Australian academics. That's why we need to grow Australian academics. That's why we need to foster the people who are in the front line to educate, move up, become academics, get themselves to a position where government are speaking to them, and it bridges that knowledge to power gap, because otherwise we're going to end up with US solutions in Australia that don't get up because the government can't endorse them. They don't, there's a mismatch. And so we do need to grow Australian academics. The only way to do that is to have Australian academics at these networking platforms on a national stage, showing that we're interested, showing up with a delegation, showing that our government stands beside its academics in this. And so the Australian Centre for Disease Control is really in a position to finally grip this up and marry up with academics so that we eventually get this right for this country. It is controversial. I'm one of those dags who listens to Senate estimates and Senate time, and you know, there were senators arguing about the Australian Centre for Disease Control and its relevance. You hear the sprays and you sort of holding on to the steering wheel thinking, how can you say that? But, you know, we're a democratic country and I'm open to all opinions, good or bad, it's all education. So, yeah, the slide back was actually the 19 tenets of the Australian NAPS. This is the CDC for the USA. I apologise. This slide really is an older one, but it shows at the moment that this is the hierarchy for CBRN within Australia, and this is where the CDC would sit now. It would supplant itself as the senior government organisation for all things as it relates to public health and sort of CBRN management. The NATO best practice model is quite definite about what it aims to achieve. It's quite clear. CBRN medical treatment is number 4, but that's also because that's the natural order of things. Operating in a CBRN environment is probably something you would see frontline staff, police, fire, army do. Naval ships could be out there and be operating in a CBRN environment if they were under attack or floating through a nuclear waste area post-event. And then you sort of get onto the day-to-day and real management of managing casualties, because post an event, all there is casualties. That's it. There's not any counteraction. After that happens, the whole system focuses on health and the environment. So what does a path forward look like? Well, Australia will need to decide what a minimum viable capability looks like. And in order to establish that, they need to set realistic expectations that are suitable for Australia, feasible. You know, something that we're able to do, something that we can rely on, supply chains we can rely on. We are a very big country, vast distances to cover. Our solutions need to be realistic. They also need to be imaginative. They also need to be out of the box. You know, if we always do what we've always done, we'll always get what we've always had. We need to work towards sovereign solutions. Currently for CBRN, we are so reliant on international support and global solutions. It's not that there aren't things within Australia that are being developed, it's that they're being on-sold to other countries and sold back to Australia. And in part, that's because we are a risk-adverse nation, and so much of Australia doesn't want to carry the risk for their own sovereign solutions. We actually have the solutions internal to Australia. And I think it's time to start embracing that and backing ourselves. But we need to probably take a hybrid approach to capability solutions and management, and say, yeah, you know, internationally things are done big and very well and we need some of that. Realistically, it can take 10 months to 2 years just to get some ColdPro over here from the UK. Booking a plane to move those big monsters takes ages. It doesn't happen, it's not IKEA. And so unless we are absolutely sure that we're going to back this and buy it, we have to also have internal solutions that are fail-safe in the event that global nations don't go, oh, there's a CBRN event, we're going to stockpile what we have. And we've seen it happen already. We're turning inwards, we're saving ourselves, stuff you, contracts are cancelled, we'll see you in courts over the lawyers, happy with that. And then we're just completely left out of the dark. But as it stands, being one of the last countries to remediate, we're not really at the top of the priority list for any equipment. We haven't been in the game. So we're very late to, you know, we're going to have to do a lot of sucking up, or we're going to have to build something ourselves. And we really need to start sorting out our public health emergency management approaches and informing the public and the community that this is a risk and it is a part of the dialogue, and you do need to consider what's going to happen if Darwin is nuked. So one of the things that we need to do is really look at consultation. We need to know who our specialists are and lean into them. Industry is a great source of specialist knowledge. There are so many people out there desperate to give their knowledge in consultation that are not being heard. And it's the same with our academics. But one of the biggest problems is the workforce. And CBRN is a huge impact on the workforce. It's probably the wickedest problem. Training a workforce to work in that stuff and sustain an 8-hour shift. Think about a nurse who runs. You know, we're not all special forces soldiers. We're not all firefighters. A lot of people would struggle to get through an hour in that stuff. I've done it. I've done a 5K run in this stuff with a weapon and webbing, and it's really, really hard. Doing a nursing shift as an untrained person in this stuff, you have to manage rosters, workforces. People might just walk out and say stuff, but I'm not doing that. I didn't sign up for that. You know, this is stuff that the healthcare system needs to consider. Do you train teams that you have on standby to manage a high rotation of staff who are well trained, or do you train the whole workforce and hope that they just eventually suck it up? But, you know, there are people in Australia writing really, really, really good papers on this stuff. My PhD is just not focusing on the operational level and the operational management of the hospitals. But there are some really good articles now out about managing CBRN events in emergency departments and hospitals. So I'm just going to skip forward. So The key for the Northern Territory is interoperability. And I say to people all the time, Duplo and Lego don't match too well, but you can make it fit. You can make a building out of Duplo and Lego. But in the event of a CBRN event, you will be relying on jurisdictional support. That's what the Australian Health Department directs for CBRN events, jurisdictional support. So do you work very closely with WA and Queensland to make sure that you all have the same kit, you're all singing off the same song sheet, the politics get put to the side, and let's all choose whether we're going to buy Duplo or Lego, because I'll be calling you. My healthcare system still has to manage all the cardiac arrests, the MIs, the homeless, the vulnerable, diabetics, the pregnant mothers. When we need WA or Queensland to come in and offer us jurisdictional support, we need to know that they can just pick up and run with what we have, or can bring their own and we can do ours. And so there's a lot of interplay across states that is required. And this is where networking and interoperability is so very essential to getting this correct. I'll skip some slides in the interest of time. I will labour the importance of industry, consulting, and academia. Academia is so important in leading this, in particular for our risk and safety. Validation of making sure we're getting this right, training the workforce, running accreditation, making sure that we publish or perish. And at the moment, we are sitting at perish, but not off the ground. So we need to raise academics. We need to be on the world stage. We need to be a part of this, and we need to get involved. We're the last people to the dance party. But there's a lot of support that academics can give government and health workforces and emergency services. We need to start getting invited to things. Finally, what they found with the Novichok incident in the UK was that all the talk about what was going to happen and how, do you decontaminate, how clean is clean, what's dirty, how much do we get rid of? And they found in the end they just dug a big hole and disposed of the whole lot of it. And this is why supply chain is so important, because you need to just throw stuff away. You could lose whole emergency bays, whole aircrafts. Think about that. If you can't clean a truck well enough, you have to throw it away. We could be throwing away all of the NT's ambulances one day in a pit. So disposability is sometimes the only solution. So thinking about supply chain and thinking about all of these things and how they impact the workforce is massive. CBRN turns everything we know about health on its head. We are talking about turning workforce over quickly. We are talking about training people to work in austere environments and chucking everything away and needing it to be replaced. Ventilator used on a nerve patient, it's in the ground. ICU beds used, something toxic on it, they're not sure if they got it clean, that goes in the ocean. But we've got to change how we think. We've got to look at our infrastructure and how we manage this. I will skip through a lot of it. A lot of it is stuff that is really, really important, but also at the operational level and not at that strategic level. The importance of this whole presentation is to get people thinking, what are the higher documents doing to support all the underpinning work that has to be done to remediate a healthcare system, to act differently, think differently, behave differently, and have widespread cultural change to be successful and to survive? Rehearsal and making sure that there is jurisdictional training and support is essential. There has not been an Australia-wide activity since 2018. That was raised in the COVID report last year. Finally, I'll leave you with this, the art of possible. I do shifts at the Hilton Hotel, to pay for my PhD, and not a day goes by I don't walk around the hotel and think, oh, that would be a good resus bay. Oh, these tunnels underneath. Oh, these are all the offices. This is where I put the ops room. I look at train tunnels and think, could we build a hospital in here that would be nuclear proof? It would be good to see more people thinking like that. Dare to dream. If you are speaking to government representatives and they haven't asked themselves the question, elevate. And I'll leave you with that. So thank you very much for your time, and thank you for the invitation to come and speak at Charles Darwin and Menzies. I hope this has been informative, and I would love to take questions if there are any. Thank you. Thank you.
Thank you, Erica. That was really interesting. Johnny, do we have any questions from anyone online? Not yet. No? Okay. Well, we've gone a little bit over. So what we might do is, are you okay for people to contact you on your email?
Yes, I am. Yes, just through erica.banash@anu.edu.au.
Okay. I'm posting this on the chat. Yeah, so that will be in the chat, and you can always contact the Northern Institute for your contact details.
No worries.
Yeah, I'd like to thank you for coming today.
Thank you for having me. I'm really happy to be.
And we have recorded this session, and we will put that up, and if we can share your slides as well.
Absolutely.
That would be great. So that will be up on the Northern Institute website shortly when we get time to edit it. And thank you very much for joining us today.
Thank you for having me. Much appreciated.